Good evening, everyone. My name is Vininder Dillon, and I'd like to welcome you to Hopkins at Home. I'm an assistant professor in the Department of Otolaryngology at Johns Hopkins Medicine. I work within the Division of Laryngology, which is everything that has to do with voice, swallowing, and the upper airway. And tonight, I'd like to discuss a topic that is of personal interest to me and something that has become increasingly important to my own patients and colleagues. I hope you find this interesting and thought-provoking and hopefully applicable to yourself. Tonight, I'm going to be talking about hoarseness and cough after COVID, the post-pandemic look at voice health. While we're not quite in the post-pandemic era as of yet, it is something we will all have to face. There will be time for a Q&A session at the end of tonight's talk. You can ask a question anytime by typing it into the chat module on your screen. And approximately 15 minutes at the end of my talk, I will begin taking curated questions from the audience. My hope tonight is to discuss two very common symptoms, hoarseness and cough, in light of the current COVID pandemic. I do not intend to directly correlate the virus with voice changes or cough as symptoms, but hope to discuss the potential implications of this pandemic on both. I will discuss COVID and its reservoir, where the infection starts and how it infects our upper airway. I will touch base on hoarseness and cough as symptoms, how they are diagnosed, and how we currently treat them. But more importantly, I want to discuss what can we expect regarding voice and cough for patients who have been diagnosed with COVID, either discharged from the hospital or quarantined at home, and ultimately the measures we can each individually take to ensure the best of our voice health now and in the future. COVID-19 has changed the way in which we perceive symptoms of cough, hoarseness, sore throat, and anything that deals with the upper airway, including shortness of breath. Some of these symptoms have become interchangeable with the symptoms tagged in COVID screening questions and ones we consider as presenting symptoms of COVID. COVID-19 travels via small droplets or aerosolized particles into the nasal tract and then into the larynx, which is indicated here by a red arrow. The larynx, also known as the voice box, is a very unique organ whose primary role is the production of sound, protection of the airway, and the gateway to our swallowing tract or the esophagus. The larynx is the focus of tonight's presentation because this is where hoarseness and cough begin. I want to show this list, which is the range of COVID symptoms provided by the CDC, only to highlight that the ones here in bold are the ones that affect the nasal tract, the larynx, and the upper airway. While none of these symptoms are specific for COVID, these are the symptoms that many of us have gotten used to when screening ourselves, others, and when being screened for COVID. So the questions to ask are, where is the virus and how does it spread? COVID-19 is part of the SARS family of viruses with 19 spike proteins on its capsule. Research has shown that it enters the nose and the mouth through small droplets or aerosolized particles. From there, the virus enters the nasal tract and creates damage on the olfactory neurons, or the nerves that control our sense of smell. This leads to loss of a sense of smell and taste for some patients. From there, it's known that the virus settles into the small grape-like gas exchange units in the lungs, known as alveoli. We understand that in this area, there is an exorbitant inflammatory response, also known as a cytokine storm. And from there, the virus can seed into other organs, including the heart, blood vessels, the intestine, and the brain, and cause multi-organ system failure on top of respiratory failure. Hoarseness on its own is a symptom that currently affects almost 1% of the medical-seeking population in the United States every year. It is more common in adults 70 years or older, and women are 1.5 times more likely to experience voice concerns than men. The most common diagnoses, for which I'll show a few examples in the next few slides, are functional dysphonia, laryngitis, and vocal fold polyps. On the other hand, cough as a symptom brings many other patients into their general practitioner offices and pulmonologist offices across the country each year. The overall prevalence of a chronic cough, which is one that lasts greater than 8 weeks, is 10 to 20% of the general population. This is a pretty high number, of which 40 to 50% present just to the pulmonologist office. It is estimated that we spend over $400 billion a year in treating cough in the United States, which is a huge cost burden to our healthcare system. The next few slides are to provide everyone some background on common findings surrounding hoarseness and cough. Hoarseness and cough are symptoms, but they do not identify the underlying problem. Hoarseness simply means a change in voice or an abnormal change identified subjectively by the individual. But the question is why and from what? There are certain questions that we may ask about the voice, including quality, timbre, pitch, and projection, as well as a history of what might have preceded the onset of the hoarseness itself. But it is important that as providers, we take the history and the examination, and for us as laryngologists, the examination is a direct look at the larynx with an endoscopy in order to base treatment. Many times, voice abnormalities are only subtle findings on exam, and therefore it does take a fellowship-trained laryngologist and high-definition technology to determine the cause for someone's voice complaint. These are a few examples of the endoscopies that we perform in the office. I want to show everyone 2 videos of the 2 types of endoscopies we perform by placing a camera either through the nose and the mouth. Here on the left-hand side is an example of a laryngoscopy. The laryngoscopy, as I'll play here, shows the vocal folds opening and closing. Here, we're able to assess for motion of the vocal cords as well as abnormality of anything that may be growing on the vocal cords themselves. On the other hand, this is a video stroboscopy. A video stroboscopy allows us to see the vocal folds in motion by freezing the ability of its vibration so that we can look for subtleties along the edge of the vocal cord as well as any gaps during phonation. Here are some common examples of what I had previously discussed before, just to give everyone an idea of what are the common things that we see currently in terms of hoarseness. The first 2 examples are of a vocal fold polyp. So this is a young teacher who came in at the end of her spring semester, and she had a cherry red lesion here that you can see on her vocal cord, which after many months of voice overuse, she noted that she had hoarseness. This is an example of a consultant who came in who also had a smaller vocal cord polyp on the opposite vocal cord. But this was after many months of traveling and voice use for his job. On the other hand, other common findings we can see in regards to hoarseness is laryngitis. This is again another teacher who presented after having a strep throat, and she had been talking through the strep throat at school, and she presented with these white patches on her vocal cords, which were affecting the vibration of her vocal cords, and it was causing her hoarseness. Cough, just like hoarseness, is also a symptom, but with many causes. The 3 most common causes of cough are postnasal drip and allergies, anything that has to do with the lungs, including bronchitis, asthma, and smoking, and heartburn or acid reflux from the GI tract. We must also review patients' medications because cough can be a side effect of the medications themselves. The most common cause of an acute cough is secondary to an upper respiratory infection, which typically lasts less than 4 weeks. A chronic cough, as I mentioned before, is one that lasts greater than 8 weeks. And these are the patients that end up coming into the doctor's offices for further evaluation. Here is an example of a woman who had a cough for over 2 decades. She came in, and this was what her laryngoscopy and video stroboscopy showed. You can see that with coughing, there's a lot of tension and contraction of the muscles of the vocal cords. And this creates chronic inflammation, which can sometimes lead to hoarseness as well. According to the American Academy of Family Practice, the prevalence of chronic cough is as high as 30%. One type of chronic cough is known as neurogenic cough. This cough, again, lasts greater than 8 weeks. It's typically a dry cough. And we believe that 46% of patients, almost half of patients that present to us, have a preceding history of a viral illness or some sort of mechanical trigger such as intubation. There is a belief that there is an oversensitization of the receptors in our larynx, which causes this cough reflex. And therefore, patients can sometimes have very specific triggers for which they describe a tickle forms, and therefore they have to cough. This leads to a vicious cycle, and it can creates a negative impact on quality of life. So what has COVID taught us about voice and cough for patients that may have been affected by the virus? I'd like to split these individuals and patients into ambulatory patients, hospitalized patients, and patients who have been intubated to discuss each of them individually. The reality is that we have only started seeing patients in a clinic setting in follow-up who have tested for COVID and were at home quarantined with symptoms. So the ambulatory patients are still ones that we have yet to see in the office. Those who are hospitalized or are intubated on ventilators for weeks, we have still not seen them because the truth is we really don't know when that patient population will be able to come into the doctor's office on an ambulatory basis. Lastly, we don't have complete knowledge, given the lack of testing, to know how many positive patients there are in order to collect a certain number of patients to review for a large study. And the ability to perform our endoscopy in the office has also changed because these are aerosol generating procedures. So this has limited our ability as laryngologists to evaluate patients completely with a direct look at the larynx as we have always been used to. Our hope, I believe, at this time is to discuss these potential implications and educate our own patients and the general public on voice health based on the research we know, what is currently coming out, in order to preserve quality of life, because ultimately voice and cough are quality of life issues that we were going to be dealing with going forward. So in terms of the number of patients that are ambulatory, these are the ones that are at home, integrated in day-to-day society, and may come into the doctor's office. Those that have COVID, again, are unknown because we are not currently testing the general population to know full adequate numbers. However, we know that patients that may have mild symptoms such as cough, shortness of breath, even fevers and fatigue, that can influence voice change. As I mentioned prior, if you are coughing for even over 8 weeks of time, there's continual inflammation of the vocal folds. And with continued voice use, despite the coughing on a day-to-day basis, it becomes a vicious cycle of cough and hoarseness. So in fact, while many of us may be asymptomatic according to the CDC guidelines, if patients have hoarseness and cough, they are truly symptomatic in the sense that they have created their own vicious cycle. And this is something we must deal with and address in the near future. Patients, on the other hand, that are in the hospital and have been intubated with a breathing tube placed into their upper airway, as shown here on the left-hand side, this is necessary in order to assist with mechanical ventilation because of the respiratory distress and failure that they may be in. They can undergo structural damage to the upper airway and the trachea. We know that there is compression of an endotracheal tube over a long period of time, which can cause changes, and patients that are intubated for COVID are no different. So this is a picture here on the right of the larynx in terms of a bird's eye view, and I just want to show you a few examples of some of the injuries that we know can be caused by having an endotracheal tube in for many weeks. This Pac-Man-like figure here is an example of a blood clot or a hematoma, which is basically a bruise or a bleed into the skin lining from having compression by an endotracheal tube. This oval-shaped blue figure is an example of what's known as a granuloma, which is a scar tissue or scar overgrowth because the endotracheal tube sits in the back of the larynx and creates sort of a friction and pressure necrosis and scarring. And lastly, you can have stenosis or stricturing of the upper airway or the tracheal cartilages, which can actually lead to persistent shortness of breath even after the patient has the endotracheal tube removed. These are all things we as laryngologists and upper airway specialists end up dealing with and are aware of. But again, we have yet to see these in our patients coming out of hospitalization with COVID. The other thing we also currently know is that when you are intubated, you can undergo voice changes. This has been studied. There are a few papers in the laryngology literature which describes what is known as post-intubation phonatory insufficiency, basically post-intubation voice changes. A group in New York, Bastian et al., published a paper almost 19 years ago which described this. And what it basically showed is that these patients, because of the endotracheal tube in place, even weeks and months after their extubation, have notches in the back of the larynx. They actually have huge gaps secondary to the pressure that the tube has placed. And what happens to the voice is that it becomes breathy and pressed. So it sounds like a very coarse voice, but it's also very weak at the same time. And these are some examples of what happens with that post-intubation phonatory insufficiency. The trio of black and white photos here that I presented is actually from the paper itself in 2001. And this last diagram, part C, shows a little notching here on the left side of the larynx. And you can see that there's this huge gap when in reality we shouldn't be missing that much space, but the tissue has been basically scarred. I have an example, this video is an example of a patient that I saw recently who was intubated for a different reason, but for 3 weeks. And here he was presented with voice issues. If you look close enough, you can see that there's notching on the right side of his vocal cord, which doesn't allow him to actually bring his vocal cords together towards the front and doesn't allow him to have a strong voice. So again, we understand this, but in terms of our COVID patient cohort, we have yet to see this, although we do expect this to be potential consequences for those patients coming forward on an outpatient basis. On top of voice changes that can occur with ventilation, we have also come to understand that there are direct consequences COVID has had on ventilated and non-ventilated patients just by the virus itself. The Lancet published a study in May 2020 about pulmonary fibrosis, which is very significant. This is basically scarring of the lungs because of the viral infection and because of the inflammatory response that occurs in the alveoli. Our lungs are our generator and sole producer of the air pressure we require to allow for strong voice quality. So in this study, they showed that up to 30% of patients that they had looked at, which were about 40 patients total, months after the hospitalization, 30% had pulmonary fibrosis. This in turn led to persistent shortness of breath, decline in daily activity, and ultimately we believe that these will have an effect on breath support, voice quality, as well as coughing. I believe we will likely see a large cohort in the future with cough, secondary to this alone, pulmonary scar, which is going to be difficult to treat and will be lifelong for many. On the other hand, some of the survivors of COVID themselves have started to publish their own outcomes in collective responses in order to bring attention to some of the long-term effects that they've faced because of the virus too. The Atlantic published a very good article in the early part of June in their health section on 640 patients who called themselves the body politic. This was a publication by a cohort of people who basically wrote up their own experience on symptoms, how many had recovered, how many were still facing symptoms, on a day-to-day basis months after they had gone home, either from the hospital or were quarantined with the virus. The vast majority of participants experienced fluctuations in their type of symptoms, and 90% of the respondents felt that they had not recovered from the virus in some way, shape, or form. The top 10 symptoms reported over the course of 8 weeks by the group included shortness of breath, tightness in the chest, dry cough, and some had reported some voice changes as well. So again, we have yet to acquire full knowledge, even from patients themselves, on patient-reported outcomes, what kind of symptoms they're facing. But the upper airway and the larynx, those patients will probably experience hoarseness and cough that we have yet to identify and treat. And lastly, I present one more paper that was published from Italy in the Journal of American Medical Association at the end of June. A group of scientists and researchers in Rome, Italy, took their own patient population who had gone home, approximately 143 patients. And you can see here that after they had gone home, they reported that up to 55% of the 143 patients had 3 or more symptoms still. The top 5 were fatigue, dyspnea, which is shortness of breath, joint pain, chest pain, and cough. So what can we expect? More hoarseness, more cough, potentially more shortness of breath? The answer is yes. So on top of evaluating the patients who we have yet to see, the question I'm hoping everyone is thinking about right now is, what can I do? What can I do right now to improve my own chances of maintaining good voice health? How should I proceed if I have concerns of hoarseness or cough, or I know someone with hoarseness or cough during this time? And what if I'm a potential COVID survivor? What should I do now that the acute virus is controlled, my symptoms have improved, but I'm still facing these issues? Well, I'd like to offer some education and consideration of what's called vocal hygiene, which is well known among laryngologists and voice professionals and voice therapists. But this is the care and consideration of our larynx and upper airway. My hope is that it guides many of you who are concerned where to go and how to address your own voice health appropriately. First, I'd like to talk about preventative measures, which have been emphasized all over the news and social media. But from what we now know, wearing a mask is the most beneficial thing we can do. This is based on recommendations in multiple studies. I myself want to present this article, which was published in Science in June by some colleagues at the NIH. They showed here in this photo very simply that if you wear a mask, your risk of viral transmission is very low. There are 2 types of particles. There's particles that are aerosolized, which hang in the air or on surfaces for sometimes up to days. And there are small droplets, which basically are produced and from talking or singing, and they basically fall to the ground. But if you wear a mask, that risk is decreased significantly. The article also discusses, or rather analogizes, the virus transmission to fumes from cigarette smoke. So again, if you can imagine, even with social distancing, cigarette smoke can travel very far, and therefore wearing a mask is very warranted in prevention of viral transmission to protecting our upper airways. The other thing here you can do is hand washing as a very important preventative measure to prevent the risk of viral transmission. Again, hand washing prevents those aerosolized particles, which may hang out on surfaces to enter our upper airways. So that's also a very important preventative measure. But when it comes to handling, for example, our own voices, I think we should start considering how we each feel first, address how we use our voice, what our vocal demand is, and our own symptoms, and then speaking with our appropriate providers or seeking the consultation of a specialist like a laryngologist or voice therapist if we have concerns. Even if we are not at risk for COVID exposure or have been tested and are negative, hoarseness and cough should not be avoided. Things to consider in this time that might also affect voice and lead to chronic cough, for example, can include even voice use. I mentioned here voice use in an era of Zoom, WebEx, and FaceTime. There are new mediums that we are using, new virtual platforms to communicate, but the use of these virtual platforms has changed the way in which we use our voice. It has forced us to speak louder, sometimes talk longer, and compensate for any background noises or nonverbal communication we have not necessarily taken into account with in-person communication. We are also wearing masks, and this in and by itself has led to more functional voice overuse or dysphonia problems with our voice. And sometimes we're experiencing strain or fatigue that we weren't experiencing before. Stress, there's a lot of psychosocial and physical stress being placed on us right now, and the larynx is no different. Functional dysphonia, which is also known as muscle tension dysphonia, is something that I've seen very often in my clinic. Muscle tension is basically the overstrain or stress of the muscles in the larynx, and that can also lead to an ineffective system and cause a lot of problems for patients. On top of stress, you have to think about our own diet, our own hydration. Are we taking in enough water? Are we using a humidifier to get enough humidity through our nose and through our mouth? Any form of dryness or lack of hydration can affect our larynx and our vocal cords, which need to be lubricated in order to work efficiently. And lastly, exercise, physical exercise, meditation even. These are all forms in which we can relieve stress and again, help our own vocal hygiene. So I wanted to quickly put forth an article which recently came out and is in pre-publication this month in the Journal of Voice. This pertains to our singers in the audience, those of you who are performers and want to know about whether or not you can return to your favorite pastime or art form. We understand, just based on the evidence we know, that singing generates respiratory particles and can super spread the virus if in large, for example, choral events that had been noted in the United States and abroad. This, along with the interpersonal interactions that accompany a vocal performance, this has led to the termination and interruption of many engagements and group participation around the US and the world. And while the evidence is sparse still regarding how singing itself may increase the risk even over conversational voice use, the authors of this study, which is a large group of very well-known laryngologists and voice professionals, have actually suggested that we may be able to return to singing at some point in time, albeit with some boundaries and limitations. Some of those boundaries or limitations are smaller groups in rehearsing, social distancing during rehearsing, even wearing a mask at times in order to prevent that super spread of our respiratory particles. But ultimately, our hope is that we can reestablish singing venues and engagements in the future. So this article is very promising. And lastly, in terms of cough, as I mentioned before, chronic cough is one that lasts over 8 weeks. A neurogenic cough, we believe, in 50% of patients, starts with a preceding viral illness. So if we think about COVID and cough, what is it? How are we going to treat this going forward? Right now, the ways we treat chronic cough are to tackle the behavior, to break this vicious cycle of the throat clearing and coughing, and then feeling discomfort in the throat, and then continuing to cough and clear. Cough as well can continue to lead to more voice abnormalities. So tackling the behavior and breaking the cycle is one form of treatment we have that we will have to continue to use. Resting the voice, identifying other triggers for cough will also be important. And there are treatment options with a voice therapist and medications that we currently use to treat chronic cough that we may have to implement with some of our COVID survivors that come in and present with cough. I also believe that with the pulmonary fibrosis, we're going to probably have to have a more multidisciplinary approach in treating our cough patients with our pulmonology colleagues, because while there may be a potential neurogenic contribution, some of the lung involvement with the fibrosis will also complicate things. And even with the stenosis in the trachea, which we've seen from intubated patients, this is going to be a complex treatment plan for patients, because again, this will be quality of life for the long haul, and cough is something we all deal with and are going to be seeing more of. So what does the future hold? Well, there are some unique and very preliminary innovations that actually may connect voice, cough, and COVID in the near future. Two groups currently, one out of Carnegie Mellon and most recently out of MIT in the computational science departments, are working to help determine if they can assess what's known as a voice signature or a cough signature in patients that may have COVID compared to normal individuals. And what this means is that they are taking voice recordings or speech recordings currently from COVID patients and trying to identify using computational methods whether or not there's a distinguished signature that may be different from normal cough and voice changes not related to the virus. The MIT group recently published an article suggesting that according to the computational recording, the voice signature is actually less complex, as they describe it, compared to normal voice signatures because there's inflammation in the system. And so as compared to non-infected adults, this may be something specific for a patient that may have had COVID compared to one that didn't. This research would potentially correlate voice changes, a hoarseness signature, and cough changes or a cough signature to patients with COVID and may be used as a screening protocol, even in the form of an app on your phone going forward. However, the research right now is still very preliminary. Both groups are collecting volunteer voice recordings, and none of the data can confirm whether or not a patient has COVID. But the fact that there is a potential correlation between voice, cough, and the virus is very promising. I personally spoke to one of the researchers at Carnegie Mellon, and the data is very interesting and, as I mentioned before, promising, but it still needs larger numbers before something like a screening protocol may come out of it. But this is something to keep an eye on in the near future. So in conclusion, there is conceivable sequelae of hoarseness and cough after COVID. These are symptoms which will potentially become more visible in our outpatient clinics in the months and years to come. There are effects that we know to the upper airway by the virus, and there is evidence to support long-term effects COVID may begin to have, including on hoarseness and cough. We must consider our own vocal hygiene, take necessary precautions, and speak to our physicians about our concerns. And I would recommend that you advocate for yourself, your own voice health, and seek medical consultation if you have any concerns or questions. I'd like to thank you all for your time and for being here this evening. Thank you for joining us at Hopkins at Home. Please come back to Hopkins at Home website for more programming, and everyone please stay safe and healthy. So that's the end of my talk. Thank you all again very much, and I will take questions at this time. So the first question I have is from A. Harris. The question is, please advise how to respond to continuous sore throat episodes even after multiple treatments with antibiotics. Throat feels as if it is actually closing, causing high anxiety. So in terms of sore throat treated with multiple treatments of antibiotics, I would tell you that the diagnosis is probably something that needs to be reviewed in terms of what was the preliminary cause of the sore throat, if it was an infection and from where. And in terms of the continued sore throat episodes, if multiple courses of antibiotics aren't treating the sore throat, then it might be best to come in and have a specialist take a look at the sore throat, either a general ENT or a laryngologist with that, either a laryngoscopy to take a look at the back of the throat to actually see if there's anything going on back there. The sensation of the throat closing in can be functional. It can be from repeated sore throats. As I mentioned before, the larynx is full of a lot of sensory receptors. So if we've been treated for, multiple infections or have other causes of sore throat, the throat can react by feeling like it's closing down or feeling constricted, because sometimes some of those muscles can become tight or have tension. Ultimately, it's also important, if you feel that your throat is closing in, to make sure that your vocal folds are moving and everything is open in terms of your upper airway. And I can definitely assure you that if you came in to one of our offices in performing a laryngoscopy, we would be able to see that. It definitely is anxiety provoking, but my next best suggestion would be to come in and see a specialist in the form of an otolaryngologist or a laryngologist for further review. A question from Michelle. Do you think voice therapy will be helpful for patients post-COVID who have hoarseness and cough? So this is a really good question. I think we don't have the data currently to know if that would be the case, but I believe that the answer is yes. I think that these patients that come in with hoarseness and cough, if they are survivors of COVID, and these are sequelae or consequences of COVID, even months after the initial infection, we should be taking a look at the larynx and seeing what kinds of potential sequelae may be there. Like I said before, we don't have enough data at this time because we aren't seeing these patients right now in ambulatory settings to know what the larynx looks like. But I believe that voice therapy would be something that would happen between an initial evaluation with a laryngologist and a voice therapist, ideally together with a direct look at the larynx. And based upon what is seen, if we believe it's functional or if it's a chronic cough for which we currently treat with voice therapy, then I think then yes, we should start there. From Jess, what are the mechanisms to repair damaged vocal cords from prolonged intubation? This is a really good question, and one that is very difficult to answer broadly speaking, because the answer is yes, there can be damage in multiple places on the vocal folds themselves. As I mentioned, there is this post-intubation phonatory insufficiency, which is basically notching or pressure necrosis of the very back of the larynx. When we talk, when we use our vocal cords to phonate, we're using the mid vocal fold anteriorly. We very rarely use the very posterior larynx, but the problem is if you have a huge gap back there, which we're not supposed to, the anterior vocal folds will not be able to completely close. So in that sense, there have been multiple studies looking at treatment options for patients with that post-intubation phonatory insufficiency. And many people try injections. There's an ability to actually place implants on the outside of our thyroid cartilage, which is our Adam's apple, to kind of help push the vocal folds over internally. These are all medialization procedures to help bring the vocal cords closer to compensate for that gap in the back of the larynx. I'm not sure if the data suggests that it's 100% curative. I don't believe so, but it's definitely been shown to be successful for many patients, again, in the patients that we have studied. I also believe that other types of damage, such as bruising or a granuloma, as I mentioned, we currently treat those multiple ways with medication, sometimes with surgery if necessary. Ultimately, there are many different techniques we can use based on what we see in terms of damage in the vocal cords. And that also goes the same for stenosis in the trachea. That scar tissue, if it forms in the trachea from having a tube in, currently we have multiple ways for treating that surgically. And so, I assume that if we're seeing more of those patients with COVID that come in with that damage, we're going to have to treat them the same way. From Mark, do you find that your patients come to you in enough time to receive proper treatments? When should one seek medical care? That's a great question. So it depends. Laryngology, it's the breadth and depth of voice, swallow, and breathing issues. According to our own guidelines by the American Academy of Otolaryngology, from a voice standpoint, the recommendation is if a patient, presents with hoarseness to their primary care provider, and let's say are treated maybe with antibiotics for laryngitis, or even with some time to see if it goes away, or given any other form of medical treatment, and it doesn't improve within 3 months, meaning the hoarseness is still present and or getting worse, then that's the appropriate time for that person to either be referred or seek the attention of an otolaryngologist or laryngologist for evaluation and that scope exam. I think the majority of my patients are triaged appropriately in the community that I work with. I'm down here in Bethesda, Maryland. And so that is something they have access to me within that time frame. But I think most people from a voice health standpoint, if it's been 3 months and things aren't changing or are getting worse, definitely come in. From a cough standpoint, as I mentioned, if a patient is having a chronic cough greater than 8 weeks, again, different medications are sometimes prescribed to treat for sinus issues, allergy issues, heartburn, and pulmonary issues. And if they aren't improving, then I think a laryngologist is a good person to come in and see to kind of discuss cough. And again, have an endoscopy and a direct look at the larynx. From Megan, how can people that use their voice professionally keep their vocal cords conditioned? That's a very good question. So I believe that anyone who has high vocal demand, that could be, in conversational voice, public speaking, teaching, lawyers, physicians, anyone that even socially uses their voice quite often, on top of our performers and singers. Anyone who believes that their vocal demand is high should have an evaluation with a laryngologist and voice therapist at some point in time, just to have an endoscopy and evaluation and look at the vocal cords. In terms of keeping their vocal cords conditioned, depending on the vocal demand, and if there are any complaints of hoarseness, obviously if there is hoarseness, one that lasts greater than 3 months, they should come in and seek our help and have a look. But sometimes we have performers come in every year who may or may not even have anything wrong, but they still seek medical attention because they want to have a checkup. And sometimes they come in because they know they're either going through a very heavy period of voice demand at the time, and they might want to see our voice therapist because there may be some muscle tension, or they're concerned that they're straining or overusing. So, I think that it's almost like treating a professional voice user like an athlete. It's, your voice is your instrument. And so just like you would come in and seek a physical therapist, trainer, every so often when you needed the attention, it's similar to coming in and either seeing us for medical attention or for voice therapy. So from Trevor, do you generally recommend cough suppressant as a treatment for cough in general? So a cough suppressant, which is typically some form of either an anti-inflammatory, sometimes with a pain medication kind of combined, is typically used in an acute setting. So for example, a patient with a viral acute cough that's been a couple of weeks, it's usually going to be very intense. So it's very good as it is a suppressant to be used for the most intense period of that coughing spell. but I don't believe cough suppressant is a treatment for cough. It's really meant to suppress and act as a temporary measure to help either a patient get through their day or sleep at night. Ultimately, if the cough doesn't get better within that, that 4 to 8 week period, if it becomes persistent and definitely over 8 weeks, that patient should come in and start seeking some medical attention, either through their primary care doctor or an ENT or otolaryngologist, so that we can discuss what the issues are with the cough at that time, if it's changed from when it started, and proceed forward with potentially treating them for other causes for their cough. From D. Crowley, my pulmonologist feels my hoarseness is due to inhalers. I am taking Brio daily and Pro Air as needed. Will my hoarseness go away with discontinuing medication? The answer is it's not 100% certain discontinuing just the inhaler if it's just the cause for hoarseness alone. Certainly, there are certain inhalers, specifically steroid inhalers, that we know can basically cause dryness and sometimes may cause a yeast infection or a candida infection of the larynx. And, again, that's really diagnosed when we take a look with an endoscopy. There is residue. The steroid inhalers are different steroid powders for which they're appropriately used for, pulmonary reasons, but they can leave that residue in the larynx when they're inhaled. There's no long-term damage with their use, but if a patient has been on chronic steroids and they feel like their voices are changing, I think it's important maybe not only to stop the inhaler, but to come in and have an endoscopy to actually see and make sure there's nothing else going on before we attribute it just to the inhalers alone. From Mary, is there any way to identify whether a cough or sore throat is due to COVID versus something else like allergies other than being tested for COVID-19? The answer is no. I mean, currently right now, the only way we know an upper respiratory infection is secondary to COVID in the acute period is the COVID nasal swab. Again, that's the best test we have that is specific for COVID. There is antibody testing, which has been discussed in multiple medians. I don't know if there's one that's most specific or sensitive, but the antibody test would potentially, if positive, show a person's exposure, previous exposure to COVID, and if that may be suggestive if they have hoarseness and cough as a cause for their symptoms. But right now, we have no other way to identify if a cough or sore throat is due to that without the testing. Allergies, as I mentioned previously, heartburn or pulmonary issues. When we see patients for chronic cough, for example, we recommend that patients go through formal testing for each of those, including allergy testing, pulmonary function tests and imaging of the chest, and even doing what's known as a pH probe sometimes to check for acid reflux, because these are all diagnostic measures to rule out those as preliminary causes. So if a patient came into me with chronic cough, I would sort of start from the beginning and kind of rule things out before, I even would say that it's related to an upper respiratory infection or potentially neurogenic. So that's kind of how we work chronic cough up specifically right now, just as an example. From Estelle, how did you decide to pursue otolaryngology as a specialty? I think it was a combination of mentorship and my own interest in the head and neck. It's a very unique anatomical location to kind of focus your training and your specialty. I know that my decision to do laryngology was because I found that the larynx is a very unique organ. Voice, swallow, and breathing is something we all need to do, but it's also very important to our quality of life. And I just really appreciate the nuances of what I can see and what I can hear when I talk to patients that come in for different complaints that are laryngologic related. I'm very blessed and honored to have been able to be trained in that. So thank you. From Jane, I always have more than normal phlegm in my throat. Is that concerning? Yeah, so, phlegm is a natural production body fluid that's produced by our body. The sensation of excess phlegm, I think can warrant sometimes investigation. Like I said, with an otolaryngologist or laryngologist, I have a lot of patients that have very common and similar complaints. We have to sort of discuss whether it's an overproduction, whether or not it's just kind of feeling like it's getting stuck. Is it physically getting stuck? Or are we unable to kind of swallow and mobilize it? So the normal amount of phlegm that we produce daily is typically over multiple quarts, which we swallow every day. But when it feels like it's more than normal, I think if it's been persistent for maybe months, then it's something to come in and have a longer conversation about. From Shelley, would you recommend for all who have had post-COVID-19, especially those who had mild illness, hoarseness, and cough, to be referred to pulmonology and or ENT, or can they be monitored in primary care? This is a really great question. I don't know if I have an answer, a very concise answer for this, but I believe that at this point in time, patients that have hoarseness and cough, who know that they have or were COVID positive, were quarantined, had mild symptoms, and have recovered, but have these persistent symptoms, definitely bring this to the attention of the primary care provider. If it is persistent, just like any other patient with hoarseness or chronic cough, where it becomes dysfunctional and it's causing quality of life issues, then certainly I would recommend that person take the initiative, let their primary care doctor know, and seek the attention of either an otolaryngologist or a laryngologist for further evaluation. I think that's the end of our questions. So I want to thank everyone again. They were really great questions. And again, I'm very delighted and happy to have been here tonight with you. So again, I want to thank everyone for joining us tonight at Hopkins and home, and take care and stay safe.